frequency and complication for AF treatment between ablation and cardioversion? Andrew, why don't you take this one?
The risk of cardioversions are very low, provided that the patient is adequately anticoagulated. So generally speaking, we want the patient to be anticoagulated for at least 4 weeks before the cardioversion. And the risk of a serious embolic event is probably in the range of 1 in 500 to 1 in 1,000 if they're adequately anticoagulated. If for some reason they don't have, they're not adequately anticoagulated, we do a transesophageal echo before we let them, we proceed with the cardioversion. So the risks of the cardioversion is quite low. However, cardioversion is it only treats the arrhythmia now. It doesn't prevent recurrences of AFib later. So that's the difference between cardioversion and ablation. With ablation, we can actually prevent future recurrences. And in patients with frequent episodes, this is probably the better treatments compared to cardioversion. And the risks of ablation, we tell patients, is about 3 to 4%, 2 to 3% of which will be vascular. There's a 1% chance of a serious complication like a stroke, heart attack, punching a hole in the heart, etc.
So another question for you, Andrew. For heart failure patients, are they always in PAF or flutter? And would it be PVI, ablation, or otherwise?
Yeah, I think that's a very good question. Atrial fibrillation can come in different patterns in heart failure patients. Some heart failure patients may have intermittent atrial fibrillation. Some patients have atrial fibrillation for longer, like days to weeks. Some patients, heart failure patients, have AF 24/7. I think the challenge is to try to identify and to figure out how much the atrial fibrillation is resulting in their heart failure. Sometimes the AFib is a bystander of a diseased heart, but in some cases they are the primary cause of patient's heart failure. So when a patient gets referred to us, for instance, with paroxysmal AF and heart failure, we have to take a very detailed history and go through all the tests to see how much AFib is causing the heart failure on one hand, and also how much AFib is resulting in symptomatic impairments. If we think that it's causing one or the other in a significant way, I'll be pretty aggressive with trying to control the rhythm, either with medications like amiodarone or ablation. So it has to be highly individualized because, once again, it's a procedure not without risks. But I'm very aggressive if I truly believe that their atrial arrhythmia is a significant component of the heart failure problem.
Mike, you want to answer that question I dropped? Just if you would read the question. And
sure. I received a question that says, please comment on galectin-3 as a marker for heart failure. And I'm sorry, I can't do that specifically. I think I need to be educated on galectin-3. But just a broader answer on the issue of biomarkers in heart failure, there are many that are being explored in terms of their additive clinical utility in patients for diagnosis and for prognosis. So acute decompensated heart failure, for example, is now thought of not just a hemodynamic problem, but acute inflammatory problem. And we're looking at things like HLA-G, tumor necrosis factor, catecholamine spillover, and troponin and BNP as markers in acute decompensated heart failure. In terms of prognostic impact, BNP and troponin are sort of where the money's at right now, but there may be better and more discriminatory biomarkers. But I'm sorry, I can't. I need to be educated on galectin-3 as a marker.
Christian at Near, the question for you: comment on low molecular weight heparin, Coumadin as bridging, and before surgery. I think it'll be good for you to clarify the newer generation Coumadin and the low molecular weight heparin before surgery.
So I think I discussed this as part of my presentation. So patients who are at high risk for stroke need perioperative bridging before for surgery. So usually we stop the anticoagulant, usually warfarin, maybe 4 or 5 days before surgery, and start low molecular weight heparin, which is usually a once daily or twice daily dosing. And if it's a once daily dosing, the last dose of low molecular weight heparin will be 24 hours prior to surgery. And generally on the day of surgery, the patient will receive warfarin the same day evening. But generally we'll wait for at least 24 hours to restart intravenous or subcutaneous low molecular weight heparin. to avoid local bleeding. For very high-risk patients who have had previous TIAs or strokes, or who have a recent prosthetic valve implant, we might have to start low molecular weight heparin, or we might have to start the heparin earlier. If so, we'll tend to start unfractionated heparin infusion, and we'll start at 12 to 18 hours after surgery, but that will increase the chance of local bleeding. We try to avoid that generally. I hope I've answered the question.
This question is directed to me. I have patients who have PVCs greater than 30,000 per day originating from the left ventricular outflow tract. Do you ablate? So this is a very difficult question to answer. In terms of PVCs, you have to first make a decision as to what's the origin of it. Is it a arrhythmogenic source, i.e. ARVC? Highly unlikely to be coming from the left ventricle outflow tract, but we usually think about ischemia, arrhythmogenic syndromes. Leaving that out now, if you assume this is a tachycardia that is similar to the right ventricular outflow tract, i.e. To do with the embryonic cells not migrating during the embryogenesis of the sinus node, and that this is not an issue of sudden cardiac death, then we have to consider the issue of the ectopy producing a cardiomyopathy. So usually we would image them and see if there's early stages of cardiomyopathy, is the ejection fraction down. If there is such a thing and the patient's rather symptomatic, you would consider catheter ablation. Now, the left ventricular outflow tract is a very complex structure. What appears as a left ventricular outflow tract focus could be coming truly from under the aortic valve in the septum. It could be coming from the aortomitral continuity, or it could be coming, as we've lately found out, from the coronary cusps right under the left main, or right on the epicardium next to the LAD. So these catheter ablation procedures are very risky, carries with the catheter ablation procedure significant risk. So you want to have a discussion with the patient regarding this. I have a classic story of an 18-year-old girl who was referred to me, who I mapped right under the left main, and I chose not to ablate. 2 years later, she has no more PVCs. Some centers would chase it. Others, we don't have long-term results of delivering RF on an aortic valve and finding out what happens 10, 15 years. So unless there's something pressing, you have to treat this very cautiously. It's a case-by-case decision. This is for Andrew. Regarding ablation, at which point, how many times after which do you stop ablating? Do you not ablate anymore? How many attempts at PVI would you go, is I think the question.
Yeah. The straight answer is it's highly individualized. But I think most of the time patients do well after one. So what happens is that, let's say 65 to 70% of patients do well after one. The remaining have a variable response. Some people might have a reduced AF recurrence. So I have patients who were getting atrial fibrillation 4 times a week. After the ablation, they were getting it once a month. And when you talk to them, they're happy. They're not that bothered having AF once a month. In that case, I don't do repeat ablations. But in some people, when they're still symptomatic from their AF, it's about 1/4 of the time you might have to bring them back for a second, and even less for a third. So, but I would say, 25% chance of getting a second procedure, probably less than 10% getting a third procedure. They also have to realize it's a law of diminishing returns. Every time you go in, there's a 3 or 4% chance of a risk. So we have to be really sure what exactly we're trying to achieve with respect to ablating again and again. And I think personally speaking, after 2 or 3 ablations, it's probably there's something abnormal with the patient's atrium, such as they have other risk factors, hypertension, scar, which limits our ability to control the atrial fibrillation. If that's the case, I'll talk to the patient, and we have to look into other options, such as antiarrhythmic drugs, or even a pace and ablate strategy. I know I've been in centers, trained in centers, not myself personally, who have done 4, 5, 6 procedures on the same patients. But this is, these are outliers, less than 1% probably. and I don't intend to do too many in my practice in terms of multi redos. So because every time you bring patients, there's risks, and you have to really figure out what exactly you're trying to do. So I would say more than three procedures or more, probably less than 10%.
Two last questions. The first one for Krishna, 76 years, diet-controlled hyperglycemia, renal impairment, paroxysmal asymptomatic AFib, picked up on Holter. Would you anticoagulate with Coumadin, starter on factor 10A inhibitor that are metabolized by the liver, simply monitor closely, or not anticoagulate?
So, because there's renal impairment, the direct the neuroanticoagulants are out of the equation because there's renal impairment. So the question is between aspirin and warfarin. So this is, I presume this is female. If it's female, it's easy. So because females get an additional point by the Chattis-2 as criteria. And this patient will have a score of 2. 76-year-old lady. So I'll anticoagulate warfarin.
One last question to Andrew. With a patient with symptomatic atrial fib, not well controlled with med, why not do an AV node ablation and put in a variable rate ventricular pacemaker? Patient has good LV function.
Yeah, I think that's a pretty reasonable option in certain patients. Let me highlight the pros and cons of a pace and ablate strategy. The pros of an AV node ablation strategy. So what happens is that you can put in a single chamber pacemaker and then bring them back in a number of weeks to burn the AV nodes so that they will no longer feel fast during atrial fibrillation. So the pro is that the success rate is extremely high when you do this procedure, and the risks are fairly low. But the con is that the patient will be basically pacemaker dependent for the rest of his or her life. So if a patient is relatively young, this has major implications because every 6 to 7 years, he or she will need a device replacement. Secondly, patients feel symptomatic because of the fastness of atrial fibrillation, but in some patients, the maintenance of AV synchrony is quite important. So if you do the pace and ablate strategy, even though you control the rate, you haven't you haven't taken away, you haven't fixed the AV dysynchrony, which in some patients can be quite debilitating as well. So those are the pros and cons, and I highlight to the patients. I think patient preference is important. Fairly youngish patients, I'm talking about 50s, 60s, probably even 70, they have to realize that they'll be pacemaker dependent for the rest of their life, and that may have some implications too.
All right, thank you very much. I'd like to thank Barry, Narinda, and Peter for allowing the electricians to present. Thank you very much.
Thank you to the electricians. Next year we'll have